السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lectures on stroke volume and its regulation, cardiac output, and heart failure in the cardiovascular block. These are the active learning objectives, the intended learning outcomes for these learning activities. And here we have the recommended learning resources. We mentioned in the previous lectures that the heart functions as the central pump of the cardiovascular system, and that within the heart itself there are two pumps. The left ventricle, which serves as the pump of the systemic circulation, and the right ventricle, which functions as the pump of the pulmonary circulation. The two ventricles, the left ventricle and the right ventricle, they generate outflow into the circulation. The outflow generated by each ventricle per minute is known as the cardiac output. So one of the major functions of the left ventricle and the right ventricle as the central pumps of the cardiovascular system is to provide cardiac output. The outputs of the two ventricles are equal. However, the output generated by the left ventricle into the aorta is generated with a much higher pressure than the output generated by the right ventricle into the pulmonary trunk. The pressure generated by the left ventricle is approximately 6 to 7 times the pressure generated by the right ventricle, as we mentioned in the previous lectures. The cardiac output is equivalent to the volume of the blood which is ejected by each ventricle in one beat, multiplied by the number of heartbeats in 1 minute. Hence, cardiac output Q dot means per minute, per unit time. Cardiac output is thus equivalent to stroke volume multiplied by the heart rate. Cardiac output is very well regulated, and it should be regulated according to the metabolic demands of the tissue. Thus, the basic determinant of the cardiac output is how much oxygen the tissues require for their metabolic rates. Accordingly, if the metabolic rate is increased, the cardiac output and the venous return are increased to maintain optimal oxygen supply to the active tissues, and also to obtain optimal carbon dioxide removal from the active tissues and the removal of other metabolic waste products. Just to summarize then, one of the major functions of the heart as the central pump of the cardiovascular system is to provide cardiac output with pressure. The cardiac output at rest is approximately 5 liters per minute, because at rest the stroke volume is approximately 70 milliliters and the heart rate is approximately 70 beats per minute. So if we multiply the heart rate into the stroke volume, 70 multiplied by 70, the result is 4,900 milliliters in 1 minute, which is approximately 5 liters in 1 minute. So the left ventricle generates 5 liters in 1 minute ejected into the aorta. Similarly, the right ventricle pumps approximately 5 liters of blood into the pulmonary trunk. And as you all know, the body's blood volume averages approximately 5 to 2.5 liters in the body, Thus, each ventricle pumps the equivalent of the entire blood volume in each minute. During exercise, obviously the cardiac output increases, and it can increase up to 20 to 25 liters per minute in ordinary individuals, and to as high as 35 to 40 liters per minute in well-trained athletes. The difference between the resting cardiac output and the maximum cardiac output, the maximum volume of blood which the left ventricle and the right ventricle are capable of pumping per minute, is referred to as the cardiac reserve. The second major function of the heart as the central pump of the cardiovascular system is the filling of the ventricles with adequate volume of blood during diastole before they generate adequate cardiac output during ventricular systole. Thus, the term venous return refers to the volume of the blood which enters each atrium or which enters each ventricle per minute. Cardiac output at rest is approximately 5 liters per minute, and this is the rate of flow out of the left ventricle and out of the right ventricle into the circulation. Venous return, this is flow rate into the heart, and similarly the resting venous return is approximately 5 liters per minute. Venous return is equivalent to the amount of the blood which fills the left ventricle or the right ventricle during ventricular diastole, which is known as the diastolic filling volume, multiplied by the number of beats we have in 1 minute, which is the heart rate. As you all know from the previous lectures, the diastolic filling volume is approximately 70 milliliters in 1 heartbeat, in 1 cardiac cycle, which is essentially equal to the stroke volume in 1 cardiac cycle. Thus, the cardiac output and the venous return are equal. And this is evident when we combine and when we couple the cardiac and vascular functions. Because the cardiovascular system is a closed system through which blood circulates, and the ventricles function as the central pumps of the cardiovascular system, the cardiac output should be equal to the venous blood return to each ventricle. Left ventricular cardiac output is equivalent over time with the right ventricular return, venous return. And similarly, right ventricular cardiac output passing through the lungs and back to the left atrium is equivalent to the left ventricular return. Thus, the outputs of the 2 ventricles are equal over time. The average cardiac output of the left ventricle is equivalent to the average right ventricular cardiac output over time, and the venous returns of both ventricles are also equal. It is important to regulate the cardiac pump, to regulate both functions of the cardiac pump. As we have just mentioned, the hemodynamic function of the human heart, of the ventricles, has 2 components. The first component is for the ventricles to get adequately filled with venous return during ventricular diastole, and the second important component is for the ventricles to generate adequate cardiac output with pressure during ventricular systole. Accordingly, there are two groups of factors which regulate the hemodynamic function of the left and right ventricles. We have factors which affect the pump ability to eject blood. In other words, we have factors which affect the ability of the left ventricle, right ventricle to generate cardiac output with pressure. And we have factors which affect the pump filling. In other words, we have factors which affect the venous return. These factors could be intrinsic properties of the heart and blood vessels, and this provides autoregulation of the heart pump. Or the factors which regulate the cardiac output and venous return could be extrinsic to the heart in the form of neural and hormonal factors. And these factors which are extrinsic to the cardiovascular system, they constitute an extrinsic regulation of the cardiac pump. In these lectures, we shall focus on the factors which affect the pumping ability of the ventricles. In other words, we shall describe in details the factors which determine the cardiac output and how the cardiac output is regulated according to the metabolic requirements of the tissue, and how the cardiac output physiologically varies with the different physiological conditions, and the factors which affect the ability of the left ventricles and the right ventricles to get filled with blood, the factors which affect the venous return, will be described in a separate lecture on venous return. So the factors which affect the cardiac output, as we mentioned in the previous slides, are two important major factors. Number one, the stroke volume, and number two, the heart rate, because the cardiac output is equivalent to the stroke volume times the heart rate. We will first describe the influence of the heart rate on the cardiac output in details. Then we will describe how stroke volume affects the cardiac output in details and what are the factors which regulate the stroke volume itself. Since the cardiac output is equivalent to the stroke volume times the heart rate, as the heart rate increases, cardiac output increases. However, we should note that at heart rates up to about 180 and even to 200 beats per minute, ventricular filling is adequate. Diastole is not shortened very much. Still, there is adequate diastolic period and there is adequate ventricular filling during diastole as long as there is enough venous return. Accordingly, the cardiac output per minute is increased by an increase in the heart rate. However, at very high heart rates, diastole is very much shortened and filling of the left ventricle and the right ventricle may be compromised during this shortened diastole to such a degree that cardiac output per minute falls. So this is how the changes in the heart rate affect the cardiac output. It is interesting to know that the heart rate also influences the cardiac contractility, and this is what is known physiologically as the frequency-force relationship, which we will describe in the subsequent slide. So having described the influence of the heart rate on the cardiac output, let's describe how the heart rate itself is regulated. You know from the previous lectures that the heart rate is determined by the number of the cardiac impulses which are generated by the pacemaker of the heart, by the sinoatrial node. The pacemaker of the heart is innervated by both divisions of the autonomic nervous system, the sympathetic and the parasympathetic divisions of the autonomic nervous system. Thus, the heart rate is under neuronal control. In the medulla oblongata, there are centers which are bilaterally located and regulate the functions of the cardiovascular system. We have a cardioacceleratory center, which is sympathetic in nature, and from this center, sympathetic innervation eventually reaches the entire heart as well as the blood vessels. We have another center which is also bilaterally located. This center is termed the cardioinhibitory center, which is parasympathetic in nature, and parasympathetic innervation reaches the heart via the left and the right vagi, the left vagus nerve and the right vagus nerve. Parasympathetic innervation innervates the atria, the sinoatrial node, and the atrioventricular node, and the His-Purkinje system, with very, very little parasympathetic innervation to the ventricles. And most vascular beds in the body do not receive parasympathetic innervation. Only very restricted number of vascular beds in the body receive parasympathetic innervation. So, sympathetic nerves innervate the entire heart, and when the sympathetic system is stimulated, the heart rate increases, and the contractility of the heart also increases, and we have described the effects of sympathetic stimulation and parasympathetic stimulation on contractility in a previous lecture. Sympathetic nerves release catecholamines, which are noradrenaline, norepinephrine, and epinephrine. These catecholamines stimulate the heart beta-1 adrenergic receptors. Parasympathetic nerves innervate the sinoatrial node, the AV node, the atria, and the His-Purkinje system. They do not innervate most of the ventricular myocardium, as I just mentioned. And with parasympathetic stimulation, with vagal stimulation, the heart rate slows down, but parasympathetic stimulation has little effect on cardiac contractility. Parasympathetic nerves release acetylcholine as the neurotransmitter, and acetylcholine stimulates muscarinic M2 receptors. The beta-1 adrenergic receptors for catecholamines are present on the sinoatrial nodal cells and also on the contractile myocytes. Similarly, the muscarinic M2 receptors for acetylcholine are present on the sinoatrial nodal cells and on the contractile myocytes. But since we are describing the influence of sympathetic and parasympathetic stimulation on the heart rate, we shall just focus on the beta-1 adrenergic receptors and the M2 muscarinic receptors, which are located on the sinoatrial nodal cells. The catecholamines, norepinephrine, noradrenaline, released from the sympathetic nerve endings, and the circulating adrenaline act on beta-1 adrenergic receptors and increase, both of them increase the heart rate. This is a summary of how sympathetic stimulation increases the heart rate. So this is the pacemaker potential, and this is the threshold level at which the sinoatrial node fires an action potential. So with sympathetic stimulation, this is the normal heart rate with normal sympathetic stimulation, the one in black color. The one in red color is the pacemaker activity with sympathetic stimulation. So with sympathetic stimulation, the pacemaker potential takes shorter time to reach the threshold level. Hence, the sinoatrial node, the pacemaker of the heart, fires high frequency action potentials and the heart rate increases. How does this happen? What is the mechanism? The beta-1 adrenergic receptors, beta-1 adrenoreceptors on the sinoatrial nodal cells are coupled to an excitatory G protein. And when they bind to their adrenergic receptors, the catecholamines, norepinephrine and epinephrine, activate the excitatory G protein, and this results in activation of the enzyme adenylate or adenylyl cyclase in the plasma membrane. Adenylate cyclase converts adenosine triphosphate into cyclic adenosine monophosphate. Hence, the level of cyclic adenosine monophosphate increases in the cells of the sinoatrial node, and cyclic AMP acts as a second messenger inside the cells of the sinoatrial node. When the level of cyclic adenosine monophosphate increases inside the cells of the sinoatrial node, this results in opening of sodium and calcium channel. Thus, sodium and calcium ions, more sodium and more calcium ions get in, speeding up the rate of depolarization, hence the heart rate. Another effect of the increase in the level of cyclic adenosine monophosphate inside the cells of the sinoatrial node is a decrease in the permeability of the membrane of the cells to potassium by accelerating inactivation of the potassium channels. Hence, fewer potassium ions leave the cell, and the inside of the cell becomes less negative, resulting in a depolarizing effect. The overall effect, the net effect, is swifter drift to threshold. The sinoatrial nodal cells will take shorter time to reach the threshold level. Hence, there will be greater frequency of action potentials generated from the sinoatrial node, from the pacemaker of the heart, and this increases the heart rate. On the other hand, with parasympathetic stimulation, there is hyperpolarization of the sinoatrial nodal cells, and the nodal cells will take longer time to reach the threshold level, and as a result of this, less frequency action potentials are generated than the normal state, resulting into slowing of the heart rate. So acetylcholine released from the parasympathetic nerve terminals bind to the muscarinic M2 receptors in the sinoatrial nodal cells, and this slows down the heart. The mechanism: the acetylcholine binds to the muscarinic M2 receptors and activates a different G protein which is inhibitory, which is different to the excitatory G protein which is stimulated by the catecholamines. Accordingly, the enzyme adenylyl or adenylate cyclase is inhibited, and this reduces the level of cyclic AMP inside the sinoatrial nodal cells, resulting in closure of the sodium and calcium channels, so less sodium and less calcium ions get in, and opening of potassium channels in the cell membrane of the sinoatrial nodal cells, and this results in more potassium ions get out, and the inner surface of the membrane becomes then more and more negative. Hence, this results in hyperpolarization of the cell membrane of the sinoatrial nodal cells, and it makes it more difficult to reach the threshold level and initiate an action potential. So the overall effect of parasympathetic stimulation is lesser frequency of action potentials and a slow heart rate. So this is how the heart rate is regulated with the sympathetic and the parasympathetic nervous systems, with the sympathetic and the parasympathetic divisions of the autonomic nervous system. It is beautiful that as the heart rate increases, the force of myocardial contraction, myocardial contractility also increases. And this is what we call the frequency-force relationship. So this is another way by which heart rate influences the cardiac output. One way is because the cardiac output is equivalent to the stroke volume multiplied by the heart rate, so as the heart rate increases, cardiac output increases. Another way by which the heart rate influences the cardiac output is by increasing myocardial contractility when the heart rate accelerates. So this is what we call the frequency-force relationship. These are the action potentials which are generated by the contractile cardiac muscle cells, the myocytes, when the heart rate is normal. And these are the action potentials which are generated by the contractile myocytes when the heart rate is fast. Obviously, with fast heart rates, the number of action potentials, the number of cardiac impulses generated from the sinoatrial node increases, and each cardiac impulse generated from the sinoatrial node will trigger an action potential in the contractile myocytes. Thus, the number of action potentials generated by the contractile myocytes would increase. So we'll have more plateau phases. And the more plateau phases we have in the contractile myocytes, the more calcium ions get in, and the more calcium ions released from the sarcoplasmic reticulum, so the stronger is the force of contraction. Thus, the force of contraction of the cardiac muscle is increased when it is more frequently stimulated. This frequency dependency of the force of contraction in the heart is probably due to the accumulation of calcium ions within the myocytes, as we have just described. The accumulation of calcium ions within the myocytes as the heart rate accelerates results from the increased number of action potentials per minute, the increased number of depolarization. So we have more frequent plateau phases, so more calcium entry. Additionally, with faster heart rates, the magnitude of calcium current into the contractile myocytes is increased, hence the intracellular calcium stores are increased. Both effects enhance the release of calcium from the sarcoplasmic reticulum, and also the uptake of calcium back from into the sarcoplasmic reticulum when the heart relaxes. Thus, calcium availability to the contractile proteins is enhanced, and this results in more force generation through cross-bridge cycling as we described in previous lectures. So we have finished with the influence of the heart rate on the cardiac output in details, and now we will describe how stroke volume influences the cardiac output and what are the factors which determine and regulate the stroke volume itself. The factors which determine the stroke volume are the preload, the afterload, and the state of myocardial contractility, the inotropic state, and also the heart rate as we have just described in the frequency-force relationship. So now let's define these three factors first, and then describe how they influence stroke volume and the cardiac output. What is meant by the preload? Preload is the load on the muscle in the relaxed state. And when a preload is applied to a muscle in the relaxed state, it causes the muscle to stretch. And as a result of stretching of the muscle develops passive tension. The left and right ventricles of the heart, as you all know, are three-dimensional chambers which get filled with blood during ventricular diastole. Thus, it is the volume of blood in the left and in the right ventricles at the end of diastole, which we call the end diastolic volume, which determines the degree of stretching of the myocardial fibers at the end of diastole. Accordingly, the end diastolic volume, the volume of the blood in the left ventricle, which is exactly equal to the volume of the blood at the end of the diastole in the right ventricle, this is the load which the left or the right ventricle have at the end of the diastole and before they begin to have their systole. Thus, the acceptable indices of left ventricular preload are left ventricular end diastolic volume and also left ventricular end diastolic pressure. Same thing applies to the right ventricle. Let's define the afterload. The afterload, this is the load on the muscle as it begins to contract and during contraction. Left ventricular afterload then represents the force which the left ventricle has to generate in order to overcome the aortic pressure and open the aortic valve and begins ejecting blood into the aorta. We mentioned in the 2 lectures on the cardiac cycle that the left ventricle cannot eject blood unless it generates enough pressure which slightly exceeds the aortic pressure in order to open the aortic valve and begins ejecting blood into the aorta. Hence, the afterload of the left ventricle is the aortic pressure. Systemic arterial hypertension increases the aortic pressure and hence increases left ventricular afterload. On the other hand, systemic arterial hypotension decreases left ventricular afterload. Let's define the third factor which affects the stroke volume. So this is a figure, before we describe the third factor, this is a figure which summarizes what's meant by preload and afterload. So the preload is the volume which enters the ventricles during diastole, while the afterload, this is the resistance which the left ventricle meets when it begins to contract, and it has to overcome this resistance in order to eject blood into the circulation into the aorta. The third factor which affects stroke volume is the inotropic state of the myocardium, which is known as myocardial contractility. Myocardial contractility is an intrinsic property of the myocardium independent of the preload. Thus, myocardial contractility can increase without an increase in the preload. This is an intrinsic property of the myocardium. Changes in myocardial contractility are due changes in the intracellular dynamics of the calcium ions. Thus, drugs which increase myocardial contractility usually provide more calcium and at a faster rate to the contractile machinery of the cardiac myocytes. The more calcium is available to the contractile machinery of the myocytes, the more calcium will activate more cross bridges and thereby strengthening the heartbeat. On the other hand, drugs which block the L-type calcium channels, the dihydropyridine receptors, have negative effects on contractility, have negative inotropic effects. So now we have finished with the definitions of the factors which affect the stroke volume, and let's describe how these factors affect the stroke volume in details. And just a very quick overview of how these factors affect the stroke volume. Stroke volume, as you all know, is equivalent to the end diastolic volume minus the end systolic volume, because this is the volume which is ejected during ventricular systole, from the left ventricle into the aorta and from the right ventricle into the pulmonary trunk. Stroke volume is directly proportional to the end diastolic volume. So as the end diastolic volume increases, stroke volume also increases. Stroke volume is inversely proportional to the end systolic volume. So as the end systolic volume increases, stroke volume decreases. An increase in the preload increases the end diastolic volume, hence increases the stroke volume, while an increase in the afterload increases the end systolic volume. Hence, stroke volume is decreased because stroke volume is inversely proportional to the end systolic volume. An increase in the inotropic state of the myocardium decreases the end systolic volume and hence increases stroke volume. This is how these three factors affect the stroke volume in short. And now we shall describe how these factors regulate the stroke volume in more details. And let's begin with the preload. So here in this diagram, we have preload on the x-axis, the ventricular end diastolic volume in milliliters, and the stroke volume on the y-axis. As you can see, as preload increases, stroke volume increases. The mechanism of the increase of the stroke volume when the end diastolic volume increases is because the larger the end diastolic volume, as the end diastolic volume gets larger, the more the ventricle is stretched. And the more the ventricle is stretched, the longer the initial myocardial fiber length before the ventricle begins to contract. And as the myocardial fibers are stretched, before they begin to contract with larger end-diastolic volumes. This results in higher degree of overlap between the actin and myosin filaments. Hence, more cross bridges are formed between actin and myosin, resulting into greater force and hence an increase in stroke volume. At smaller end-diastolic volumes, the interaction between actin and myosin is not optimal, and as the left ventricle is stretched with more and more end-diastolic volume, the interaction between actin and myosin becomes optimal. Thus, we would have greater force on the subsequent contractile contraction and greater stroke volume. This relationship is also explained by the greater sensitivity to calcium at greater lengths. So the contractile machinery of the myocytes become more sensitive to calcium as the myocardial fibers are stretched more during diastole and before they begin systole. So in short then, as the end-diastolic volume increases, stroke volume also increases. This is an intrinsic relationship between the end-diastolic volume and stroke volume. It is beautiful that the heart regulates its stroke volume based on its end-diastolic volume. So this is a form of autoregulation of the ability of the heart to eject blood. The more blood it gets filled during diastole, the stronger is the force of contraction, and the more blood it ejects during systole. This intrinsic relationship between end-diastolic volume and stroke volume is known as Starling's law of the heart. It was first described by the physiologist named Starling. And this intrinsic relationship reflects the ability of the heart to change its force of contraction and hence the stroke volume in response to changes in venous return. So an increase in the venous return results in an increase in the end-diastolic volume. An increase in the end-diastolic volume results in an increase in the force of ventricular contraction, as we explained in the previous slide. And the increase in force of ventricular contraction increases the stroke volume, and the increase in the stroke volume increases the cardiac output. And this curve, which shows this intrinsic relationship between the end-diastolic volume and the stroke volume, with the end-diastolic volume on the x-axis and the stroke volume on the y-axis, is known as Starling's curve of the heart, or is known as cardiac function curve. There are other versions of the cardiac function curve which we will describe during these two lectures. So the cardiac function curve can also be drawn by having the diastolic filling, by having an index which reflects diastolic filling on the x-axis. This could be end-diastolic volume, or could be end-diastolic pressure, or it could be also right atrial pressure, the pressure in the right atrium, because the pressure in the right atrium reflects the ventricular filling during diastole. It reflects filling of the right ventricle, and as you all know, the cardiac output from the right ventricle would eventually reach the left atrium and then the left ventricle, hence would also affect left ventricular cardiac output. So Cardiac output, as you all know, is equivalent to the stroke volume multiplied by the heart rate. And if the heart rate is constant, then an increase in the cardiac output should reflect an increase in the stroke volume. This is a modified Starling's curve of the heart. So this is a modified cardiac function curve where we have on the x-axis the right atrial pressure, which reflects diastolic filling. So it reflects the preload. And on the y-axis, we can either have the stroke volume or we can have the cardiac output in liters per minute. From this cardiac function curve, it is evident that an increase in the right atrial pressure results in an increase in the cardiac output. The right atrial pressure is the independent variable which affects the cardiac output. Thus, the cardiac output is the dependent variable. It is the variable which depends on the changes in the right atrial pressure. When the right atrial pressure is 0 millimeters of mercury, is atmospheric, 0 means atmospheric pressure. The cardiac output in an adult human is about 5 liters per minute at rest. Now, because of the steepness, this curve is not flat, it's steep. Because of the steepness of the cardiac function curve, very small changes in the right atrial pressure in the form of just a few millimeters of mercury can result in large changes in the cardiac output. So this is another way of having the cardiac function curve. One way is having the end diastolic volume on the x-axis and the stroke volume on the y-axis, as we have seen in the previous slides. And this way is plotting the cardiac function curve with the right atrial pressure on the x-axis and the cardiac output on the y-axis. So as the venous return increases, right atrial pressure increases and the end diastolic volume increases. And when the end diastolic volume increases, the end diastolic fiber length increases because the myocardial fibers are stretched more and more as the end diastolic volume increases more and more. Increases in end diastolic fiber length produce increases in cardiac output. Thus, in the steady state, the volume of blood the left ventricle ejects as the cardiac output equals or matches the volume it receives in venous return. The cardiac output of a ventricle should be equivalent to the venous return of that ventricle over time. And the cardiac outputs of the two ventricles are equal over time. And the venous returns of both ventricles are equal over time. Increases in end diastolic volume, increases in right atrial pressure, produce increases in the cardiac output by Starling mechanism, as we explained in the previous slides. Now let's describe the effect of preload on stroke volume using the left ventricular volume pressure loop. which was described in the 2 lectures on the cardiac cycle. So on the x-axis, we have left ventricular volume in milliliters of blood, and on the y-axis, we have left ventricular pressure in millimeters of mercury. This is the end systolic volume, and at this point, the mitral valve opens and left ventricular diastole begins. So the left ventricle begins to be filled with blood. And here we have the end of normal ventricular diastole, where the left ventricle and the right ventricle are filled with the end diastolic volume of approximately 130 to 135 milliliters of blood. Then the left ventricle begins systole, and this is the isometric contraction phase without a change in the volume. The volume remains the same, but the pressure increases. And when the left ventricle generates enough pressure to overcome the aortic pressure, it opens the aortic valve and ejection of the blood begins. So the left ventricle begins to eject the stroke volume. This is the rapid ejection phase, and this is the slow ejection phase, and here we have the end of left ventricular systole. So this volume is the end systolic volume, and now the left ventricle undergoes diastole without a change in the volume. So this is the isometric relaxation phase. So now this is the volume of blood which is ejected with an ordinary end diastolic volume. So what happens when the preload, when the end diastolic volume increases? Now, if the venous return increases, the left ventricle would get filled with more blood, and this increases now left ventricular preload. So now the left ventricle is filled with, say, 140 or 150 or even more than this. So left ventricular preload has increased. Now this is the end of the end diastole of the left ventricle. This is, and the left ventricle begins systole. So this is the isometric contraction phase. Now at this point, the left ventricle would have generated enough pressure to overcome the aortic pressure and opens the aortic valve, and now ejection begins. So now, can you see the stroke volume which is ejected now by the left ventricle has increased because the end systolic volume is the same. So more stroke volume is ejected from the left ventricle into the aorta as the left ventricle gets filled with more blood in the diastole which precedes systole. So we have finished then with the detailed description of how preload affects stroke volume, how the end diastolic volume affects stroke volume, and now let's very briefly list the factors which affect the preload, the factors which affect the end diastolic volume. End diastolic volume is increased when blood volume increases and when the venous return increases. So any factor which increases the venous return would increase the end diastolic volume. For example, increased venous tone, increased skeletal muscle pump during exercise, because the muscles would squeeze the veins, resulting into more venous return. Increased negative intrathoracic pressure would also increase the venous return. We've described the factors which affect the venous return in more details in a separate lecture on the venous return. Also, with stronger atrial contraction, end diastolic volume would increase. On the other hand, end diastolic volume is decreased when the subject stands and with factors which decrease the venous return or factors which limit the ability of the left or the right ventricle to relax and get filled with adequate blood. like for example when there is increased intrapericardial pressure or when there is decreased compliance of the ventricles. So we have finished then with the detailed description of how the preload affects the stroke volume and the cardiac output, and let's now describe how the afterload affects the stroke volume and the cardiac output. And we have all agreed that left ventricular afterload is the mean aortic pressure. So when the aortic pressure is reduced, when the left ventricular afterload is decreased, the velocity of shortening of the left ventricular myocardial fibers during systole increases. Hence, with reduced left ventricular afterload, the left ventricle can eject blood more rapidly, and this increases the rate of blood ejection into the aorta, so that now less blood is left within the left ventricle at the end of systole, resulting in a decrease in systolic volume. Accordingly, stroke volume increases as a result of the decrease in the end systolic volume. This is the end diastolic volume with normal left ventricular afterload, and this is the end systolic volume with normal left ventricular afterload, and this is the ejected volume, the stroke volume. So as you can see from this figure, as the afterload of the left ventricle decreases, the amount of blood which remains by the end of systole decreases, and the amount which is ejected increases. Thus, the end systolic volume decreases and the stroke volume increases, because now the velocity of shortening of the myocardial fibers of the left ventricle increases with the reduced left ventricular afterload. The opposite is true when left ventricular afterload increases. Thus, an increase in left ventricular afterload decreases left ventricular stroke volume, because the left ventricular end systolic volume would have increased. This happens in conditions of aortic stenosis and systemic arterial hypertension, where the left ventricle must respond and compensate to changes of the afterload. The left ventricle thus must work harder, and the work of the left ventricle must increase in an attempt to maintain the stroke volume constant in the face of an increased afterload. So let's now describe in details how an increase in left ventricular afterload results in a decrease in left ventricular stroke volume. Here we have a modified Starling's curve, a modified cardiac function curve, where we have on the x-axis left ventricular end diastolic pressure as an index of preload, and on the y-axis we have stroke volume as usual. So this is a modified Starling's curve. And the curve in blue is a normal Starling's curve when the afterload of the left ventricle is normal, when the aortic pressure is normal. An increase in afterload leads to an increase in the end systolic volume and a decrease in stroke volume, as we mentioned earlier. Thus, an increase in afterload shifts Starling's curve down and to the right, from A to B. So these are Starling's curves with increased left ventricular afterloads. Of course, this curve should have higher afterload than this curve. With the increased afterload, the velocity of shortening of the left ventricular myocardial fibers decreases, so this reduces the rate of ejection from the left ventricle, and as a result of that, more blood is left in the left ventricle by the end of systole, resulting in an increase in the end systolic volume. And as the end systolic volume increases, the stroke volume decreases. So from this curve, when the afterload increases and the curve is shifted down and to the right, at the same preload, the left ventricle with increased afterloads would eject smaller stroke volume than when the left ventricle has a normal afterload. On the other hand, a decrease in the afterload shifts Starling's curve up and to the left from A to C. So now at the same preload, a left ventricle with reduced afterload would eject more stroke volume than the same left ventricle with a normal afterload. Let's again describe the effects of afterload on stroke volume using the left ventricular volume pressure loop. So this is again the end systolic volume. The left ventricle is get filled with blood during diastole, up to 130 to 135 milliliters of blood. So end diastolic volume hasn't increased. Preload is stable, it hasn't increased. Now the left ventricle begins systole with isometric contraction phase, but as it begins to contract, the left ventricle realizes that it is now facing a higher afterload. So the afterload is not 80 as normal, but the left ventricular afterload is now 110 millimeters of mercury. So the left ventricle should work harder to generate these 110 milliliters of mercury and slightly above 110 milliliters of mercury in order to open the aortic valve and begins ejection into the aorta. Thus, the increased left ventricular afterload would result into slower velocity of shortening of the left ventricular myocardial fibers, and hence the volume of blood by the end of systole, this is the volume which remains by the end of systole, the volume which remains in the left ventricle by the end of systole is now larger than when the left ventricle has a normal afterload. Hence, the stroke volume is decreased. Now, let's describe the third factor which affects stroke volume and cardiac output in more details, and the third factor is myocardial contractility, myocardial inotropic state, inotropy, the effects of sympathetic stimulation. So this is again Starling's curve of the heart, the original Starling's curve of the heart with the end diastolic volume on the x-axis and the stroke volume on the y-axis. With sympathetic stimulation, the cardiac contractility increases and shifts Starling's curve up and to the left. So a left ventricle with increased sympathetic stimulation would eject bigger stroke volume at the same end diastolic volume. So the increase in stroke volume then is not the result of the increase of the end diastolic volume. The increase in the stroke volume is the result of the increase in myocardial contractility as a result of sympathetic stimulation. And you need to know that at rest the heart is under sympathetic tone, and the mechanism by which sympathetic stimulation influences contractility was described in a previous lecture. So catecholamines, norepinephrine and epinephrine, they have positive effects on contractility. They have positive inotropic effects. Just to remind you, norepinephrine and epinephrine, they enhance calcium entry into the cardiac muscle cells. This is a left ventricle with decreased sympathetic activity. So with decreased sympathetic activity, the left ventricle would eject less stroke volume than the same left ventricle when it has normal sympathetic activity. Parasympathetic stimulation has little effects on contractility, and this is due to the innervation pattern of the heart as we described in previous lectures. Here we have the effects of sympathetic stimulation on the modified Starling's curve of the heart, the cardiac function curve, with the right atrial pressure on the x-axis reflecting the preload and the cardiac output on the y-axis. This is the left ventricle with normal sympathetic stimulation. So with increased sympathetic stimulation, the cardiac function curve is shifted up and to the left, which means that at the same preload, the left ventricle with increased sympathetic stimulation would eject more cardiac output. So again, the increase in cardiac output is not the result of the increase in the preload. Rather, it is because of the increase in contractility. On the other hand, with decreased sympathetic activity, or when the left ventricle fails, Starling's curve and the cardiac function curve shifts down and to the right. So now this left ventricle with decreased sympathetic activity, or when the left ventricle fails, would eject less cardiac output when it is compared with the same with the cardiac output ejected by the same left ventricle with the normal sympathetic activity. Finally, let's describe the effect of sympathetic stimulation on myocardial contractility using left ventricular volume pressure loop. So this is the end systolic volume. Now the left ventricle is this is the original end systolic volume before the left ventricle has increased sympathetic stimulation. So this is the end systolic volume without norepinephrine. Now the left ventricle is filled with blood till it reaches end diastole, and here we have the end diastolic volume is approximately 130 to 135 milliliters. So the end diastolic volume hasn't increased. Left ventricle begins now with systole. This is the isometric contraction phase, and there is no increase in afterload, or there is no decrease in the afterload, because it is the decrease in the afterload which is expected to increase the stroke volume. Now, this left ventricle with ordinary end-diastolic volume, which hasn't increased, and with a normal afterload, with an afterload which is not lower than normal, when it is stimulated with the sympathetic nervous system, can you see now, it would eject a bigger stroke volume, and less stroke volume would remain inside the left ventricle by the end of systole. So we have finished now with the detailed description of the factors which affect the cardiac output. And now let's very briefly describe the physiological changes which we may have in the cardiac output. During the first 3 hours after meals, cardiac output is increased by approximately 30%, and this is in order to enhance blood flow in the intestinal circulation. Later months of pregnancy are associated with more than 30% increase in the cardiac output due to increased uterine blood flow. At environmental temperatures above 30 degrees centigrade, the cardiac output is increased, and also at low environmental temperatures, the cardiac output is increased because of shivering that increases blood flow to the skeletal muscles. With increased sympathetic activity during anxiety and excitement, cardiac output might increase by 50 to 100%. Sitting or standing from the supine, from the lying position, decreases the cardiac output by approximately 20 to 30%, because when someone sits or stands suddenly from the supine, from the lying down position, venous return decreases, and the decrease in venous return decreases the end-diastolic volume, so this decreases the cardiac output according to Starling's mechanism. Obviously, the cardiac output increases during exercise. So with moderate exercise, the cardiac output might reach 12 liters per minute as a result of an increase in stroke volume and heart rate. So with moderate exercise, the heart rate increases to 200% of the resting. The resting is 70 beats. 200% of the resting means 140 beats in 1 minute. Severe exercise increases the cardiac output 500 to 700%. 500% means that the cardiac output is now 5 times the resting cardiac output. 700% increase in cardiac output means that the cardiac output is 7 times the resting cardiac output. So during severe exercise, the cardiac output might go up to 25 to 35 liters per minute. We might have pathological changes in the cardiac output. Some conditions might result in pathologically low cardiac output, or they might result in an increase in the cardiac output. The causes of low cardiac output include low venous return, as in hemorrhage, or reduced myocardial contractility, as in heart failure, or when there is a tachyarrhythmia, like what we have in atrial fibrillation with fast ventricular response, or with ventricular tachycardia. Because when there is atrial fibrillation with fast ventricular response, or when there is ventricular tachycardia, the period of diastole is shortened very much, that there will be no enough time for the left or the right ventricle to get filled with enough blood. Hence, end-diastolic volume is compromised and the cardiac output is decreased. Marked bradycardia also results in pathologically low cardiac output, as incomplete heart block, because the cardiac output is simply stroke volume multiplied by the heart rate. So if the heart rate is 35 or 40 beats per minute, like what we have in complete heart block, or 20 beats per minute, this will definitely result in pathologically low cardiac output. Causes of high cardiac output include hyperthyroidism, AV fistulas, when there are fistulas between an artery and the vein, or between arteries and veins, fever, anemia, because these are all associated with hyperdynamic circulatory states, and also when there is an anxiety as a result of sympathetic stimulation. So the normal resting cardiac output of a normal adult is approximately 5 liters per minute. However, the cardiac output can be pathologically low or pathologically high. Some conditions result in pathologically low cardiac output, and others result in pathologically high cardiac output. So then we need to measure the cardiac output. So how do we measure the cardiac output? Someone may say, simple, the cardiac output is 5 liters in a normal adult at rest. Correct, but this is a normal adult. In someone who is not normal, the cardiac output, the resting cardiac output, is not 5 liters per minute. We can measure the cardiac output with the use of two-dimensional echocardiography. So this is the echo machine which we use to measure the cardiac output. Two-dimensional echocardiography, as you can see here on the monitor, records real-time changes in ventricular dimensions during systole and diastole. So here we have the left ventricle during systole, the same left ventricle during diastole. This is the right ventricle during systole, and the same right ventricle during diastole when it is in relaxation. So by recording these changes in ventricular dimensions during systole and diastole, two-dimensional echocardiography computes stroke volume, which when then multiplied by the heart rate gives the cardiac output. Another way for measuring the cardiac output is to use Fick's principle. Fick's principle assumes that the amount of oxygen which is consumed by a particular organ is equivalent to the amount of oxygen delivered to that organ by the arterial blood minus the amount of oxygen which is left in the venous blood which leaves the organ. The amount of the oxygen which is delivered to the organ by the arterial blood is equivalent to the oxygen content of the arterial blood multiplied by blood flow through the organ. Blood flow is Q. The amount of oxygen which is left in the blood after it has passed through the organ, which is left in the venous blood, is equivalent to the oxygen content of the venous blood multiplied by blood flow through the organ, which is Q. Still Q is the same. Thus, the amount of oxygen consumed by the organ is equivalent to the amount of oxygen delivered by the arterial blood minus the amount of oxygen remaining in the venous blood. Q is common, so we can rewrite the equation in this form. So the amount of oxygen consumed by the organ is equivalent to Q multiplied by oxygen content of the arterial blood minus oxygen content of the venous blood. From this equation, we can calculate flow through the organ. So flow through the organ, Q, is equivalent to the oxygen consumption divided by the difference between the oxygen content of the arterial blood and the oxygen content of the venous blood. We can use the same principle to measure flow through all organs of the body. And you all know that flow through all organs of the body is the cardiac output. So the cardiac output would be equal to the amount of oxygen consumed by all organs of the body, which is known as the resting oxygen consumption. And we can measure this using the spirometry, divided by the oxygen content of the arterial blood measured by taking a sample of the arterial blood minus the oxygen content of the venous blood measured by taking a sample of the venous blood. And so this is the equation which we use to measure the cardiac output using Fick's principle. When we insert the values of the normal oxygen consumption, the normal arterial oxygen content, and the normal venous oxygen content in a normal subject, the cardiac output would be 5,000 milliliters or 5 liters in 1 minute. This is the case when the subject is normal. We are assuming that his resting oxygen consumption is 250 milliliters per minute. But this subject might not be normal. And if he's not normal, then his resting oxygen consumption might not be 250 milliliters of oxygen in 1 minute, and his oxygen content of the arterial blood is not 20, and his oxygen content in the venous blood might not be 15 milliliters of oxygen in each 100 milliliters of blood. We might also use ultra-fast computer tomography to measure the cardiac output. And again, the ultra-fast computer tomography records the changes in ventricular dimensions during systole and diastole, but it records these dimensions more accurately than two-dimensional echocardiography. Here we have the left ventricle in systole and the right ventricle in systole, and the same left and right ventricles in diastole. So by recording changes in the ventricular dimensions during systole and diastole, ultra-fast computer tomography can compute the stroke volume, and then we multiply the stroke volume by the heart rate. We have known that the left and right ventricles function as the central pumps of the cardiovascular system, and that the left and right ventricles are adequately filled with blood during ventricular diastole and then produce adequate outputs with appropriate pressures during ventricular systole. Let's then see what happens when there is failure of either the left or the right ventricle, or when both ventricles fail. Heart failure is defined as the inability of the heart to eject adequate cardiac output to satisfy the metabolic requirements of the organs of the body. Thus, the resting cardiac output may be low, normal, or even elevated despite the presence of heart failure, as long as this particular level of cardiac output is inadequate for the needs of body organs of blood and oxygen. Hence, the major manifestations of heart failure are inadequate cardiac output, and this inadequate cardiac output results in building up of blood in the veins behind the failing ventricle, behind the failing left ventricle or behind the failing right ventricle. The building up of blood in the veins behind the failing ventricle increases the venous pressure. Heart failure might develop because of intrinsic myocardial causes within the myocardial tissue itself. These causes result in reduction in ventricular contractility, as in cases of myocardial infarction, where there is death of cardiac myocytes as a result of blockage of the coronary arteries, and also in cases of cardiomyopathy and myocarditis. Heart failure might also develop when there is a cardiac arrhythmia, for example, in severe bradycardia. In cases of complete heart block, the heart will not be able to produce adequate cardiac output. Similarly, in severe tachyarrhythmias, where the diastolic filling period is greatly shortened, the left and the right ventricle will not be filled adequately with blood during diastole, and hence will not produce adequate outputs during systole. Cardiac failure might also develop as a result of extrinsic causes, causes which are not within the myocardial tissue. These causes make it more difficult for the failing left ventricle or for the failing right ventricle to eject blood. So when there is systemic arterial hypertension or aortic stenosis, the left ventricle would find it difficult to eject adequate stroke volume into the aorta, as we have described in the previous slides. Pathophysiologically, cardiac failure might be classified as left or right-sided failure. So here we have, this is the normal distribution, and this is the picture when we have right-sided failure. This is the picture of the circulation when we have left-sided failure. So since the left and right ventricles of the heart are two separate pumps, it is possible for one ventricle to fail independently of the other ventricle. In left-sided failure, in left ventricular failure, blood which is normally ejected to the lungs by the right ventricle and eventually reaching the left ventricle by the pulmonary veins and left atrium is not pumped out by the failing left ventricle into the systemic circulation. This results in the accumulation of blood in the pulmonary circulation, hence increasing the pulmonary capillary pressure, and this results in serious filtration of fluid in the lung interstitial space and alveoli. This is the serious complication of pulmonary edema in left heart failure. On the other hand, in right-sided failure, when the right ventricle fails, blood which is normally pumped by the left ventricle, this is our left ventricle, into the systemic circulation and eventually reaching the right ventricle through the superior and inferior vena cava and right atrium, is not pumped out by the right ventricle into the pulmonary circulation. As a result of that, blood accumulates in the systemic circulation, increasing the pressure in the systemic capillaries, and this results in filtration of fluid in the body tissues and systemic edema. Though each side of the heart can undergo failure separately, dysfunction of one of the ventricles may lead to a sequence of events that make the other ventricle also fails. Another pathophysiological classification of heart failure is the classification of heart failure into acute and chronic heart failure. Acute heart failure is when the left or the right ventricle fails acutely over a short period of time, over hours to days. And this happens when there is sudden serious abnormality of the heart, as in cases of massive myocardial infarction, in cases of arrhythmias, valve rupture, and when there is acute infection with sepsis. Acute heart failure results in sudden reduction in the cardiac output and blood pressure and decreased perfusion of vital organs, and in acute left-sided failure, the serious life-threatening complication of pulmonary edema might develop. Acute heart failure can be immediately life-threatening because the failure develops rapidly and the heart and the body do not have enough time to undergo compensatory adaptations. Acute heart failure is usually left-sided failure, but acute right-sided failure can also occur. Acute left-sided failure is obviously more serious than acute right-sided failure, since acute fatal pulmonary edema develops in acute left-sided failure as a result of building up and damping of the blood in the pulmonary circulation. Cardiogenic shock might develop following acute heart failure if the left ventricle becomes unable to pump enough cardiac output to even keep the tissues alive. So this what happens when there is acute left-sided failure. Let's describe chronic heart failure. Chronic heart failure is a long-term condition which develops over months to years, and it is associated with the heart undergoing adaptive responses in the form of hypertrophy or dilatation. These adaptive responses can, however, be deleterious, as we will see in the subsequent slides. As we mentioned earlier, that when one ventricle fails, it might lead to a sequence of events that make the other ventricle also fails. So when the left ventricle fails, a sequence of events begin and end with failure of the right ventricle. So we end up having biventricular failure, and this is what we call congestive heart failure. So when there is increased systemic vascular resistance as a result of systemic arterial hypertension, or when there is aortic valvular stenosis, these result in increased force of left ventricular contraction, because the left ventricle would have to work harder to overcome the increased systemic vascular resistance. When the left ventricular contraction increases, when the left ventricle works harder, the demand for the left ventricle for oxygen increases. So this results in increased left ventricular hypoxia. And when this happens, the result would be decreased left ventricular contraction, thus increased left ventricular end diastolic pressure, because blood would accumulate in the left ventricle because the left ventricle would not be able to eject adequate stroke volume. And when the left ventricular end diastolic pressure is elevated, the pressure in the left atrium is also elevated, and the pressure in the pulmonary veins is also elevated, resulting in pulmonary congestion and possibly pulmonary edema. Pulmonary congestion decreases oxygen supply to the left ventricle further, so this aggravates left ventricular hypoxia. So now the body would try to decrease the chances of developing acute pulmonary edema, and it does so by inducing pulmonary vasoconstriction. So when pulmonary vasoconstriction happens, the pulmonary vascular resistance increases, and this reduces the chances of developing acute pulmonary edema. However, the right ventricle would suffer, because now the right ventricle would have to work harder to overcome the increased pulmonary vascular resistance, and hence the right ventricle would eventually fail. So hence, left ventricular failure might begin a sequence of events which lead to right ventricular failure and the development of biventricular failure and congestive heart failure. Now let's describe the physiological adaptation to chronic heart failure, the compensation mechanisms. These again develop when the heart and the body have adequate time to develop these compensatory mechanisms. So when the cardiac output is decreased, the mean aortic pressure is also decreased, and this results in decreased firing of action potentials from the baroreceptors present in the carotid sinus. With the decreased firing of carotid sinus baroreceptors, sympathetic stimulation is increased, resulting in vasoconstriction of the arterioles, hence the afterload is increased, vasoconstriction of the veins, hence the venous return increases and the preload is increased, and increased sympathetic stimulation also increases the heart rate and force of left ventricular contractility. Accordingly, the cardiac output and blood pressure are increased. However, the afterload has increased, and this is not good for a failing heart. The preload has also increased, and this is not good for the failing left ventricle as well. Other compensatory mechanisms include the decreased renal perfusion, which happens when the cardiac output is decreased, activates the renin-angiotensin-aldosterone system. So renin is released by the juxtaglomerular cells and cleaves angiotensinogen to angiotensin 1. Then angiotensin 1 is converted to angiotensin 2 when blood flows through the pulmonary circulation by an enzyme known as angiotensin converting enzyme. Angiotensin 2 causes more vasoconstriction, so the blood pressure is increased, and the afterload is increased further on the failing left ventricle. Angiotensin II also causes sodium and water reabsorption from the kidneys, hence increasing the plasma volume and the preload. And when the preload is increased, the cardiac output is increased according to Starling's mechanisms, and the blood pressure is hence increased. However, again, the increase in the preload is not good for the failing left ventricle. Angiotensin II also causes release of aldosterone from the adrenal cortex, resulting in further reabsorption of sodium and water and further increase in the plasma volume and in the preload. Angiotensin II also causes myocyte hypertrophy and myocardial tissue fibrosis and enhanced sympathetic activity. Another compensatory mechanism which develops in congestive heart failure is when the effective circulating blood volume decreases, the actual blood volume in fact increases in heart failure, but the effective circulating blood volume decreases. And when this happens, the posterior pituitary gland releases antidiuretic hormone vasopressin, which increases water reabsorption from the kidneys and also causes vasoconstriction. So these compensatory mechanisms, they are great, they are very good if there is acute blood loss, but they do not help much with the failing left ventricle. Why is this the case? Because the increased afterload, the failing ventricle has to work against, and because of the increased preload that the failing ventricle has to pump out, and because of the retention of salt and water. The retention of the salt and water increases blood volume, as we mentioned, and this might precipitate peripheral and pulmonary edema. Heart failure passes through the compensated heart failure, and eventually compensated heart failure might become decompensated heart failure. There are factors which result in progressive heart failure, and these factors contribute to decompensation. What are these factors? For example, prolonged sympathetic activation of the heart results in downregulation of the myocardial adrenergic receptors. So the adrenergic receptors decrease in density and sensitivity to norepinephrine and epinephrine. Consequently, the inotropic and chronotropic responses of the heart cannot be elevated, cannot be increased in parallel to the increased body demands. Vasoconstriction of the arterioles under enhanced sympathetic activity increases the systemic vascular resistance and hence increases the afterload which the failing left ventricle has to work against. When there is increased left ventricular afterload as a result of systemic arterial hypertension or aortic valvular stenosis, the left ventricle has to work harder to overcome the increased afterload, and it might undergo concentric hypertrophy. And when this happens, there will be imbalance between the oxygen supply and the oxygen need of the left ventricle, because when the left ventricle undergoes hypertrophy, its oxygen requirement increases. And when this imbalance between the oxygen supply and the oxygen requirement happens, this results in further deterioration of the ability of the left ventricle to generate force during systole. The excessive salt and water retention is not good for the failing left ventricle and might contribute to decompensation. Because with excessive salt and water retention, the left ventricle will be over distended and has to consume more energy in order to generate more wall tension, so that it can develop the required ejection pressure according to a biophysical law known as Laplace's law. Here we have some figures which summarize the compensatory mechanisms and also the factors which contribute to decompensation. Atrial natriuretic peptide, this is a hormone which is released from the myocardial cells in the atria, and in some cases also the myocardial cells of the ventricles, in response to volume expansion. Brain natriuretic peptide is a natriuretic hormone initially discovered in the brain but released primarily from the ventricular myocytes. Both atrial natriuretic peptide and brain natriuretic peptide are major antagonizing agents of the renin-angiotensin-aldosterone system. So in heart failure, atrial natriuretic peptide lowers the systemic vascular resistance by inducing vasodilatation and inhibits the renin-angiotensin-aldosterone system. Let us now very briefly describe the clinical picture of left-sided failure and right-sided failure. The clinical picture includes symptoms and signs. The symptoms and signs of left-sided failure are essentially the results of the reduced output of the left ventricle into the systemic circulation and the building up of blood in the pulmonary veins and pulmonary capillaries, resulting in pulmonary congestion. Important symptoms of left-sided failure include cough, blood-tinged sputum, exertional dyspnea, which is the feeling of shortness of breath on exertion, orthopnea, which is shortness of breath, which occurs when the patient lies flat, and because of this feeling, the patient would have to sleep propped up in bed or sitting in a chair. Other important symptoms of left-sided failure include paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea refers to the attacks of the severe shortness of breath and cough, which generally occur at night. So, an attack of paroxysmal nocturnal dyspnea usually awakes the patient with left-sided failure from sleep and may be quite frightening. Tachypnea is an important sign of left-sided failure. Tachypnea means an increase in the rate of breathing, and patients with left-sided failure also have increased work of breathing. Another important sign of left-sided failure is cyanosis, which is bluish discoloration of the skin and the mucous membrane, suggesting severe pulmonary edema. And when we auscultate the lungs in patients with left-sided failure, we may hear rales or crackles or crepitations. These are terms for the same sign, and these are fine crackling sounds which are heard initially in the lung bases, and when left-sided failure is severe, the crepitations will be heard throughout the fields of the lung, and this suggests the development of pulmonary edema. Other signs of left-sided failure include lateral displacement of the apex beat as a result of enlargement of the heart because of left ventricular dilatation or hypertrophy, and a gallop rhythm, an additional heart sound, a third heart sound might be heard when we auscultate the heart. A gallop sounds like this. Here we have a diagram which summarizes the clinical picture of right-sided failure, and similarly, the symptoms and signs of right-sided failure are the results of the reduced cardiac output of the right ventricle into the pulmonary circulation and the building up of blood in the systemic veins and the systemic capillaries. Important signs include dependent pitting edema, swelling in the hands and fingers, ascites accumulation and retention of fluid in the abdominal cavity, hepatomegaly and splenomegaly, enlarged liver and spleen, and distended jugular veins. Because in right-sided failure, right atrial pressure increases, and this increased right atrial pressure is transmitted to the big veins in the neck, because there are no valves between the right atrium and the big veins. Hence, the jugular veins would appear distended, and there would be an increase in the jugular venous pressure as seen in this picture. We can see the jugular venous pressure up to the angle of the mandible in this patient. This is a picture of ascites, which means accumulation of water, retention of fluid in the abdominal cavity, and here we have pitting edema, which is a very important symptom and sign of right-sided failure. Here we have a table which summarizes the clinical pictures of left-sided and right-sided failure. And that's the end of these important learning activities. And here we have the intended learning outcomes again. And thank you very much for listening.